Hi, everyone. I'm Barry Boyce, founding editor of Mindful and mindful.org. And as part of Mindful's Healing Healthcare Summit, I'm delighted to be hosting Michelle Hood. Hello, Michelle. Executive Vice President and COO of the American Hospital Association, and Dr. Michael Sook. Hello, Michael. Chair of the Musculoskeletal Institute and the Department of Orthopaedic Surgery at Geisinger Health, and a distinguished member of the AMA Board of Trustees. In this session, we'll be discussing preventing physician burnout, including suicide prevention, building habits for well-being, and leadership that can build organizational habits for well-being as well. Please note that you can purchase lifetime access to all of our Healing Healthcare Summit content in a downloadable format at mindful.org/healthcare. I'd like to begin by briefly introducing myself and our presenters today. In 2013, I co-founded Mindful Magazine and mindful.org. I'm a longtime journalist, meditator, meditation teacher, author, and editor. Our distinguished guests today have extensive lists of accomplishments, which you can find online, but allow me to present some brief bios of them before we get started. Michelle Hood is Executive Vice President and Chief Operating Officer of the American Hospital Association. She previously served as President and CEO of Northern Light Health, a Brewer, Maine-based $1.8 billion integrated health system, providing services across the state of Maine. Prior to her time at Northern Light, she served as President and CEO of the Sisters of Charity of Leavenworth Health Systems, Montana region, as well as President and CEO of the region's flagship hospital, St. Vincent Healthcare. Before coming to the AHA, she served on the association's Board of Trustees and Executive Committee and on the University of Maine System Board of Trustees. Michelle holds a BS in biology from Purdue and a master's in health administration from Georgia State. During her 14 years at Northern Light, among other initiatives, she focused on healthcare policy and design models at the state and national levels, keenly aware of the pressures on hospitals to succeed in a rapidly changing healthcare environment. Michelle also believes strongly in administrators' need to speak the language of clinicians. And speaking of clinicians, Dr. Michael Sook, a board-certified orthopedic surgeon, was elected to the American Medical Association Board of Trustees in June 2019. An active and engaged leader from his earliest days in organized medicine, Dr. Sook was the first medical student and first Asian American elected to the AMA Board of Trustees in 1994. He's the chair of the Musculoskeletal Institute in the Department of Orthopaedic Surgery at the renowned Geisinger Health System based in Danville, PA. He received a BA in African American History from Carleton College before simultaneously completing an MD at the University of Illinois College of Medicine and a JD MPH with special certification in healthcare law at Boston University School of Law and School of Public Health. Dr. Sook later completed an MBA from the University of Scranton. Throughout his career, he has been a vocal leader on public health issues, including the role and importance of organized medicine, resident work hours, social determinants of health, and numerous other public health concerns. Dr. Sook is also one of the nation's leading clinical voices for well-being through connections with nature, outdoor recreation, and unstructured play. All right, so let's begin. We'll have some structured play. I wonder if, to start us off, if each of you could share with us your assessment of the scope of the problem of physician burnout and physician suicide. So perhaps, Michelle, you want to start?
Sure, I would be glad to, Barry. So those of us who have worked in healthcare for decades, like I have, know that burnout isn't a new phenomenon. I mean, we have been dealing with this in some regard for many, many years, for many, many reasons. The drivers of burnout include, unfulfilling work, inefficient work, lack of control to provide the best care to patients, meaning and purpose in work, work-home conflicts and balance. And those have been around for some time. And I think the new thing is that they're becoming more pronounced. Suicide generally is the convergence of multiple risk factors, the most common being untreated or inadequately managed mental health conditions. And we can talk a long time about why that happens, the stigma of mental health care and care needs. But unfortunately, we lose nearly 400 physicians to suicide each year. And women nurses are at a statistically significantly increased risk of suicide than women in any other profession. So put those two together and think about 3 years of a pandemic with US deaths totaling over 900,000, workforce and supply shortages, and a country divided on vaccine mandates. On top of that, clinician burnout, and we've got a really tremendous crisis on our hands. While Mayo's Wellbeing Index found that physician burnout actually declined in the first months of the pandemic, the continued onslaught has seen 61% of physicians reporting experiencing burnout often, a nearly 53% increase since 2018. So we can't ignore the fact that we have got a major situation on our hands on top of all the other workforce issues that we are dealing with.
Yeah, thanks, Michelle. And I would add, I think that great assessment and statistics is presented. I would say that the scope beyond just the numbers is significantly impactful for how we deal with healthcare. We know that, burned out physicians tend to have less engagement at work. They tend to produce lower quality work, and they tend to have less empathy. And so these are kind of the softer things associated with this concept of burnout that has, as Michelle points out, has existed long before anyone started studying it. I think it started to come a lot more to the fore as we began to hear more about physician suicide. I think, it was a kind of a not so well kept secret before some very dramatic recent news stories about prominent physicians committing suicide and the underlying reasons why. And even though that may be the terminal portion of the extreme versions of burnout, it indicated that there were some simmering elements of these things that we considered to be elements of burnout that have existed within our health systems. And as Michelle points out, a number of contributing factors. And for physicians, I would say that probably the main common factor is this question of being valued as a physician. And when your internal sense of value is hampered by the external validation of that, or the lack thereof, I think it creates a recipe for elements of what we are now calling burnout, but really disengagement from work. We'll talk more, I'm sure, about the specific elements of those things, but at the end of it, for me, it's this question of people and the value we attribute to them and the value they attribute themselves within the healthcare system.
So Michelle listed a number of sources of burnout and sadly suicide. And you mentioned a few things, Michael. Is it, first off, would you say there are systemic problems we have, that there's a way that we've been running things that has desperately needs to be looked at? Or, is it vary greatly from organization to organization? Or, how do you unpack, if you're trying to attack this problem, what are the key things to be looking at, the top 3 or 4 or 5?
Okay, I'll take that first, Michelle. It's,
Mhm.
I would say that, in many ways, there are unintended consequences of progress in healthcare, right? So as we moved beyond, I think, very significantly, this idea of a paper record and the inefficiencies that would be caught within that, we moved headlong into the world of electronic records, which have unintended consequences of creating a different type of work. And those workflows were not adequately worked out before we began this headlong process. And we're learning a lot about that now. We have learned some interventions that can help make that easier. But the bottom line is we want doctors to be treating patients, not to be typing into records, just as a fundamental element. And as we've increased that burden of documentation and the responsibility resting on physicians, I think that's created an undue workload that has allowed physicians to feel, again, in this concept of value, more like a scribe, less like a physician, as a fundamental element. It's not to say that progress is wrong. It's just to say that we are now seeing some of the unintended consequences of moving in that direction, for which we need to create some meaningful solutions to allow a new workflow to emerge and allow doctors to return to that aspect. I think another thought that I have is that's important in this is as physicians become more in the employed nature. We know that just last year that more than half physicians for the first time became what we call employed instead of independent practice. Again, unintended is, whatever choices that people make to enter in those types of practice agreements, it's a supplementation of maybe more of a corporate value to what they're doing than the individual physician value. Again, not necessarily a bad thing, but the corporate values of access and work and production and things like that, those can erode into a individual physician's psyche in terms of why they went into the profession in the first place and whether or not they feel fulfilled as they're practicing in those areas. So those are just two things that come to my mind.
Yeah, I can't agree with you more. The dissonance between the vocation of medicine and the actuality of the way medicine is practiced today. And as you mentioned, Michael, one of the most glaring pieces of evidence around that is the administrative burden and the percentage of time that clinicians are using of their very valuable time to, instead of connecting with patients, working through EMRs that were really built as billing systems and not care systems, is a tremendous burden. There's a number of efforts going on across the country right now, gaining steam, hopefully with some great results to come, about trying to address those administrative burdens. Also, there's regulatory burden. The fact that our doctors know that they're not always giving care in the site of service that is best for the patient, but they're restricted from their ability to manage that by all of the regulations that the Medicare and Medicaid and commercial insurance programs bring to the table. So their lack of ability to control the sites of care and how they deliver that care really push up against their professional psyches, as Michael said. So, and then you add on top of that this pandemic, and you just can't ignore the impact on our frontline clinicians during this time as they've taken on the burden of quote unquote, unfortunately normal issues, and then fear of exposing themselves and their family members to coronavirus, trying to be spokespeople for their communities around what are the risks and the benefits of everything from vaccination to restricting visitation, the workforce shortage. It's just a tremendous burden.
Michelle, it's interesting you said that. I would just piggyback on a thought in this kind of pandemic world. You have physicians who have that added responsibility to represent science in the community. And oftentimes when that is challenged, it can be very detrimental, right, to what we think we're doing, what we believe. And the frustrations that, have come out now, even almost 3 years after the pandemic started, is just this sense of disbelief that vaccines are somewhat of a hoax, or that, that it's just your opinion.
Yeah.
And that fundamentally, even the pandemic has eroded into that same professional psyche. Is what am I here for, right? And if everything that I can believe and say is relegated to just my opinion.
Right, and we hear stories all the time about our clinicians who used to be able to walk, through their grocery stores on the way home to pick up dinner with their scrubs on and feel good about their community members approaching them and thanking them and asking them for their opinion. And now looking at them in, some sort of disbelief about that they're part of some larger situation that they don't have faith in. It's a terrible burden.
It's interesting. I want to come back to what you were saying about vocation versus employee and role in a corporate setting. But just for a moment, I want to dwell on this notion that it seems like doctors have been thrust into a public health role more than, which brings its own set of challenges. You're not just treating individual patients, but in public health, you're a spokesperson for the whole community. And you're saying that that's really putting a lot of pressure on doctors at this point.
Barry, I would say I think that doctors have always been somewhat in the public health sphere to advocate for healthy behaviors, healthy lifestyles, modern medicine, etc. But I think what the pandemic has made very challenging is that it's the relegation of that responsibility to just one man's opinion or one person's opinion, right? It's the disregard for actually the recognition of whether there's science and there is actual, a method to the madness of what people are promoting in the world of modern medicine. And I think that part of it is actually somewhat disturbing, right? Is the commercialization of opinions. I share a funny anecdotal story. I had a colleague of mine who shared with me that members of his community were following somebody on a blog that had over 2 million followers, saying that vaccines were not based in science. But 2 million people read this, right? And he felt particularly disturbed because he was seen as just one person who had one opinion versus somebody who had 2 million followers. And that to me for him was really quite disturbing, as an example.
Yeah, I think that our clinicians have been thrust into a position of spokespersons and interpreters of science that has not been static. The idea that what was best known as truth in March of 2020 is nowhere near truth in January of 2022, just because of the advance of our knowledge. And we just are needing to interpret all of this data as it comes out. And how do you, as a physician on the front line, how do you not only interpret that for your patients, but we're throwing so much at them on a day-to-day basis at all of our at all of our institutional organizations in healthcare delivery. It's remarkable that we are as healthy as we are today in view of what we've been through in the last 24 months.
So thank you. So there being an erosion in the respect for the profession even takes a toll on an individual physician. It relies on trust and respect for the profession in that role. So related to that is the sense that medicine, becoming a physician or a nurse or in any number of roles in healthcare is a vocation. And yes, one is now, as you're saying, over half of physicians are now employees too. But why is it important to the well-being of a physician to have that sense of a vocation? Why is that meaningful?
Well, for me, I'll take that first, Michelle. For me, it's again, it rolls back to this concept of value, right? So how are individuals valued within themselves, and how are they valued within the context of society? I mean, to go on to be a physician is a pretty significant commitment, right? It's the educational commitment. It's a significant financial burden. Most physicians go into it with an ideal sense of purpose as to wanting to help either individuals or help populations find a way to get healthier. And I think that the most successful systems out there that are in the world of kind of employment of physicians succeed because there's an alignment of the corporate values and the individual values. So allowing physicians to become people that they wanted to become as they became healers, while at the same time, co-aligning with the larger resources of a system to help them achieve that population sense of making people better. And so in my view, there are many healthcare systems out there, and some do it extremely well. And the common theme there is a co-alignment of what I think is corporate value and individual value as to why doctors and systems work together to make populations better. I'm very fortunate to work at a place that I feel has met this. And one of the things that we do here that I believe helps give physicians a sense of autonomy, some degree of mastery and purpose in what they do as physicians within a larger system, is that we value our physicians through something called the social compact, right? And we have identified certain things that are critical to both the physician and the health system. And it rolls into things that are not measured by RVUs or by how many click boxes I checked on my EMR, but it's things like, what did you do to improve access to patients, right? What did you do to help recruit and retain physicians? What did you do to help teach the next generation? And there are two critical criteria: is be a good doctor, and the last one is be a good citizen. So when you look at those 5 things, it's hard to say, yeah, I got 90% of that right. But if that is what we value physicians on in terms of how we compensate and how we see docs, to me, that goes a long way, because it allows the individual to say, how am I going to meet those metrics? I want to be a good doctor. I want to be a good citizen, right? And there's not a grade associated with it, but it's an internal challenge for you to meet that. And I think that, again, the merging of the corporate world, larger healthcare system world, to an individual's values, I think co-align pretty well. We're not perfect, but at the same time, I think it's an important measure to allow physicians and healthcare workers, I think, feel very valued within the system. Just one example.
Yeah, I think that's a great example. I would say that we're still seeing young people come into nursing and physician education in numbers that are impressive. There's probably not a shortage of practitioners coming into the field. I think the roles of those clinicians are changing and should change going forward. And in my mind, it really doesn't make a difference whether a physician is part of a small independent group or part of a health system, as long as both match that individual's values as far as what it is they want to accomplish in their career and in their profession. There are many, many fantastic examples of systems across the country that are engaging, empowering, unleashing the power of clinical leadership
Mhm.
to help in the struggles and challenges that we have around population health management and transforming the healthcare delivery system and providing career paths and roles for physicians to not only use their clinical expertise, but also bring their passion for why they went into the vocation to start with to make a difference. And I think that's fantastic. I think we're all looking for that, and people keep saying, well, why hasn't it had a transformational effect yet? I think it's just a matter of time. I'm hoping that we're getting close to that apex of the change curve. And young people, I mean, we had 80,000 qualified nursing students, potential nursing students, turned away from nursing school last year because we didn't have enough clinical faculty or clinical sites to train them. So we've got to transform the way healthcare education is provided for nurses and for physicians. And, you know, I've got a son who's a doctor, and we talk all the time about the fact that, you know, it's a team sport, and we got to learn to deliver healthcare in a team-based environment. And so we've got a lot of transformation to do, but I don't think I'm not pessimistic about it. I'm actually optimistic about it. Certainly we've been through a heck of a 2 years, and we've still got another year ahead of us as far as I'm concerned. We're not near the end of this. But we're learning a lot, and we've got great leaders who have taken us through an unbelievable time. We're going to look back at this. Michael and I are going to tell our grandchildren about living through this and working through this, and be proud of what we've done. So yes, it's taken an unbelievable toll on the resilience of our workforce, and we have new things to bring to the field to make sure that we're better prepared the next time.
Yeah, Michelle, I'm not sure if our grandkids will believe us.
I know, that's why I'm trying to write it down as we go along, because this is a story that no one's going to believe.
So you've both been discussing some key initiatives, and some innovations. I think I'm sure our listeners would love to hear anything more you have to offer in that regard, in terms of, you know, what are the key things we need to be doing and moving forward now, the things that are already in place in some systems that could be shared more broadly, or you know, new ideas on the horizon.
Yeah, I'm not sure these are new ideas, but just a reiteration of a couple of things that both Michael and I have talked about. You know, as a field, we have not been great about optimizing technology. And, you know, we can point to the EMR as a burden, but it's also a huge asset if we just figure out how to put it together in a way that makes sense. And we haven't done that. We've got big data at our fingertips at this point. We've got predictive analytics, we've got precision medicine, we've got all those things that come as a result of the investments we've made. So help us unleash the impact of that technology as a true assistive to care delivery, and changing our care models going forward is one. The other is, I mentioned healthcare is a team sport, and not just in the inpatient environment or the ambulatory environment, but across the continuum of care. We've got people in care sites that don't need to be where they are, or it's not best for them to be where they are. My mother-in-law was admitted to a hospital today. She took a fall in her bathroom, and the worst place for a 90-year-old woman is in an inpatient care unit. I mean, we've got to do better. We got to do better about that. And we've got to figure out that mental health is health. It's not an adjunct to physical health. It's part of the equation. So those are the three things I would mention.
Abhishek, I 100% agree. Your focus or suggestion of mental health is really critically important. It is, again, I like the way you said it, the mental health is health and not an outlier specialty or disease or disease state. I would say some practical things that I think I've found very interesting is, we recognize that EMR is both a boon and a bust, right? So one of the things that I've seen at different places is the emergence of this clinical informatician, right? This whole profession of people who really specialize in clinical practice and becoming really facile at changing and enhancing EMRs. I think that's something that continues to grow in importance. And attendant to that is, we have a committee here, and I'm sure others have something similar. We call it the Get Rid of Stupid Stuff Committee, right? And that's where, everyone runs into something that they hate about the EMR, but oftentimes don't have a place to go, right? And it just becomes a part of your day to day. But having this committee allows us to take an individual's input and recognize that we have something that we could change to enhance to make better. Lots of changes have occurred as a result of that, inadvertently or on purpose have saved a lot of time and made things make more sense. But culturally, I think that dialogue is critical, right? Is that it's a tool that is constant in evolution, and creating a culture within an institution that allows for that constant and continuous quality improvement of that critically important infrastructure, I think it will go a long way to allow physicians to feel engaged and somewhat more in control of the work environment they live in.
So in terms of the better implementation of the technology leading to better well-being for the people working in the front lines of healthcare, is that largely a matter of investment or bringing in the right kind of people? Or I love the, don't do stupid things committee. That's one implementation. What will move the needle? Because we've been hearing a lot about EMR for years. So many doctors complain about it. What would move the needle?
For me, we're missing some not only critical links in terms of the input on how to affect and change EMRs, but we're also missing some interoperability of how EMRs affect the larger system. So for example, internally, when you have issues with EMR that don't communicate to, let's say, your scheduling office, or it doesn't connect to, in my case, the operating room, where I can, with one button, put something in EMR and make sure that all of the elements that are needed for the next step in surgery are taken care of, right? So I think the next evolution of this is not just information gathering, but it's information actuation, right? What are we doing with that, and how does that enhance the larger ecosystem of what we're doing? So one button, it's the Amazon Easy button, or it's the Staples Easy button, right? I want to be able to see a patient one day and talk to them, get their history, indicate them for surgery, and in that EMR contains all the elements that will populate the next scheduling, the phone call for when they need to come in, the pre-operativization labs they need to get drawn, and then all the way down to the equipment I need in the operating room. That's a future that I would love to see happen. But so when we talk broadly about technology, technology certainly needs to be internally tweaked. But I think a next step in the evolution is to take the technology to make it work seamlessly with all of the elements in what we do. That's a future that I hope will happen.
I think I heard you saying, Michelle, then when you get to that kind of day, then physicians will turn the corner and actually begin to see how helpful it is rather than what a burden it is, and enhance their ability to work in a team fashion.
Yeah, I think that's true. And I think taking Michael's example a bit further, that if you think about the continuum of care
Mhm.
and how information technology can help, say, this is a patient that has an 80% predictability of needing a post-acute inpatient facility of some sort. Let's start working on that day 1 rather than day 5, and connect to those community caregivers and those home health providers and those post-acute care inpatient facilities. I mean, you can imagine connecting the entire ecosystem of healthcare delivery in a way that we're not close to today. We're just not close to it.
Yeah, totally agree.
So, just a few final thoughts. I wonder if you could, each of you, say something about leadership. How do you lead in a way that fosters both personal well-being habits, but organizational or cultural well-being habits? I'll be frank. I mean, often physician-led organizations are criticized for not being innovative in terms of leadership. So whoever wants to start first in terms of talking about leading for well-being.
So I'm glad to start. I mean, this is a challenge that has been with us for a long time. I've been a healthcare administrator, ran hospitals and health systems for 37 years before I joined the AHA, and in every situation, it's from academic medicine to rural healthcare delivery to integrated healthcare systems and large multi-state organizations. Leadership is always challenged to walk the walk and introduce programs and services and processes that connect leadership to all parts of the organization in a way that helps people meet challenges on a day-to-day basis and set a strategic vision that people can get excited about. That's really the role of leadership, is to paint that picture of where we're going, and in some respects how we're going to get there, although that how often changes from day to day depending upon things like a pandemic. So having empathy and expecting empathy of your own leadership team. One of the things we're working at throughout the American Hospital Association with our members, our 5,000 hospital and health system members, is leadership skills today are very different than they were 5 years ago, but even different than they were at the beginning of pandemic, because we're leading teams now that are exhausted. And how do you lead in that kind of environment? What new skills and competencies do we need? We need to be a little more flexible and less rigid than maybe we were when we were taught how to lead hospitals and MBA and MHA schools years ago. And recognize that even our leaders they're struggling. They're looking for new skills and new resources and new tools. So empathy, it's great for mental health. It's great for your own mental health. Self-empathy is a skill, but uh, recognizing that and building that into our structures.
Michelle, it's difficult to follow, but to follow you on that, because I agree with you 100%. The empathy question, leads to, the discussion of kind of cultural value again, right? And that's the sense that, in the context of physician burnout, or even as a precursor to suicide and others, that there's a humanity that exists even among physicians, and recognizing that fallibility is okay is a difficult thing, right? I mean, we have work to do. We got to go do it. No one else is going to do it if you're not there, right? But there are times when you just can't perform, and having a self-recognition of performance impairment, and then having an environment that allows you to recognize it, right? I think creates a culture of what I would say is acceptance and some permission space to be able to be human in the world of burnout and things like that. And, the other thing I would say from a leadership perspective is I have, certain philosophies that I follow and things like that. But I would say that the three most important questions that I ask as a leader that are critical to improving anything are really very simple. It's, are you any good? Are you getting better? And how do you know? And that can directly be applied to our approaches on things like burnout or cultural assessment, is having the courage to stand up to the reality of those answers, right? Can, I think, be an important aspect to leadership and really being able to address in a transparent way some of the things that we oftentimes may or may not want to know, right? So in the context of burnout, are you any good at dealing with it? Ask the question, and how many, systems are out there accurately and adequately and giving time to really assessing what their environment is. And then you can know if you're getting better by constantly putting attention on it. So just a thought that I have that I think is important to just ask simple questions to get progress on such an important topic.
Great. Those are good touchstones. Humanity, empathy, and honest inquiry, and modeling that too, it sounds like. Is there anything else you'd like to add before we wrap up?
For me, Barry, I would just say that, these conferences or these conversations are so important. And Michelle and I are two voices in a large pool of people who care very much about these issues. Organizationally, we're both part of organizations that have to work in concert to address these things. So appreciate very much the opportunity to share.
Absolutely.
Yeah, I just add that the importance to pause every once in a while, both for yourself individually, but the teams that you're leading, and just say, let's take a deep breath and recognize where we are in this challenging environment, and have some introspection. Very important.
Yeah, that's great. In the mindfulness world, there's a term that comes from a longtime leader, woman, Janice Martirano, who wrote a book, Finding the Space to Lead. She talks about purposeful pauses, taking a purposeful pause, like you're saying, intentionally knowing, all right, we need to stop. Maybe when you stop, you ask that question like Michael was asking, are we good at this? How are we doing? How are we doing today? Hey, this has been great. Thank you so much for your time today, Michelle and Michael, and those of you who have tuned in. In closing, I just want to add a few things about Mindful, who's sponsoring this summit. Mindful Magazine is the world's leading secular mindfulness publication. You can access our digital library of thousands of articles, guided meditations, and videos, plus get 6 beautiful issues delivered straight to your home throughout the year. We're pleased to offer Healing Healthcare attendees a special subscription rate. Go to mindful.org/healthcare-subscribe to learn more. Please rate this session before you leave. There's a rate session button below your video in Wova. It will take only a minute, and your input is very helpful to us. And thank you all for your time.